Assalamu alaikum and welcome to the show Mindful Matters on Radio Al Ansar, 90.4 FM in Durban and 105.6 FM in Pietermaritzburg. A show that promises to provide an hour of inspiration, information and motivation with me, your host, Nazia Iram Osman. This is a pre-recorded show, so unfortunately we can't take your call or WhatsApp messages. The topic for today is mental disorder in men. Our society continues to perpetuate the myth of male strength and invincibility. Although times are changing, many South African men still feel that it's unmanly to admit to weakness or vulnerability. So the saying, cowboys don't cry. So what happens when a man finds himself battling with a mental illness? How does he explain this to his colleagues and friends that he just can't cope anymore? And what is the best approach that he can take in order to regain control of his life? Stats show that most mental illnesses are more frequent in the female population. Major depression is twice as common in women as it is in men, and women dominate in nearly all anxiety disorders. There are a number of theories that have been postulated to explain this uneven distribution. Some experts believe that it is connected to the hormonal imbalance in women, while others believe that men are merely underreporting their experiences. Females do tend to come into contact with health professionals more often than men do, and women are socialized into seeking help more readily. Both of these factors could influence the gender difference reflected in the stats. Although half as many men as women are reported to suffer from depression, the rates of suicide in men is 3 times more prevalent than in women. So men aged 18 to 24 form the highest suicide group in many countries. Once again, experts point back to the fact that fear and shame often keep men with mental problems from seeking help. If left untreated, depression can result in poor work performance, substance abuse, and broken families. Sometimes suicide appears to be the only solution left for desperate men. Men frequently commit suicide by more violent means, such as hanging or the use of firearms. And to tell us more about this is our esteemed guest, Dr. Zuber Moola. Dr. Zuber Moola is a renowned psychiatrist in Durban. Welcome, Dr. Moola, to Mindful Matters.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thanks for having me.
It's a pleasure. And I have to say, we have to reflect on this. You are our first male guest on Mindful Matters. And I think that in itself is telling. For female issues are more spoken about. And I think as females, we just talk more. But we also reach out more and I think seek help, connection, whatever you want to call it. While I think men, and you can tell me if I'm generalizing, need to deal and probably reflect or distract a bit more.
Yeah, I think you're right about that. For a long time, we've known this, that with mental health disorders, like you've pointed out, that females are more, well, there's a higher incidence in females, but it's not as straightforward as that. Like you mentioned, there's other factors at play as well. So, yeah, and there's many reasons as well that females may seek help or may be treated. Even then, overall, there is most people, male or female, are not recognized in terms of their symptoms, and they don't seek help. So even though females do seek help more than males, there's still a huge need to identify and recognize and treat mental health problems in both males and females.
Okay, so I hear you saying that, look, females do come up a bit more, but generally there is, I think, statistics to show that most people don't reach out for help.
That's right.
I don't know if I'm correct in saying this, and you could correct me, that I think there was about, from all the mental illnesses, most of them are not diagnosed, only 27% or some minute percentage actually get the help that they need.
That is true.
Yeah.
It's a very low figure compared to other conditions. Can you imagine someone with diabetes being undiagnosed, or more than 2/3 of people with diabetes being undiagnosed? That'll make the headlines.
Exactly, and I think
mental health
it's the
disorders
stigma. It's the stigma around it that, if you have diabetes, shame. But if you have some mental condition, snap out of it. Isn't that the normal?
That is true, yeah. Look, things are changing in terms of information, education, access to health. But many factors play a role as well. One of the factors that just came to mind is it all comes down to money, and economically as well, with the economic crisis globally in the last 10-11 years. One of the first things that will be cut or given less funding will be mental health. So the emphasis then moves to other things as well, to other conditions.
Right.
So so that too plays a role. But like you pointed out, with females, unfortunately, they are in the lead when it comes to mental health problems, and across the board, really, like you said. But again, what researchers have tried to do is to try to break it down. Is there a certain kind of depression, certain kind of well, not anxiety, because females are
that one.
in the lead throughout there. But yeah, so with depression, like you said, the female to male ratio is 2 to 1. Anxiety is like 3 to, well, it's almost 2.5 times more. The only sort of condition where males predominate is in substance abuse.
Okay.
And here the ratio would be even 4 to 1 in terms of males. But again, very very frequently this is not recognized, because what do you mean by substance abuse? You've got your alcohol, cannabis, other illegal drugs, but there's also over the counter abuse, where again females are much more likely to abuse those kind of medications.
Like painkillers you're talking about? Or?
Painkillers, yeah. I'm sure you must have heard in the US there's a huge move, and many of the big companies, drug companies, have been sued or have had to pay huge fines because of the use of codeine and opiates in many forms. So this is a problem that we've recognized for a long time. It keeps the rehabs going as well. They have to make money, but this is how they do it.
Yeah.
But actually, opiates, for example, are a huge problem. And I'm very frank with my patients that if you go up the ladder in terms of opiates, codeine, eventually you're going to get to wunga. And it's not very far up. It's just about 3 steps up. It's codeine, morphine, pethidine, and then you've got wunga, which is heroin. So it's something which is quite serious, and in terms of the withdrawals are about the same.
Serious, yeah.
So it's available over the counter without a prescription.
So can they mistakenly get addicted? So just say someone
Yes.
has pain, some condition that they're trying to self-medicate or...
Absolutely. Look, substance abuse, it's a whole a topic on its own, but it's almost always there's a reason behind it. So you have to find out why. Why do you do it? What does it do for you? How does it help you? If I can use that word.
Almost like a coping mechanism or
Yes,
self-medicating.
yes, absolutely. So no one really goes out trying to say, I'm going to get addicted to this, and almost everyone wants to stop using. But the key thing, I think, that you mentioned as well, is to identify and to recognize, to know yourself.
Yeah.
So this will help you in terms of first of all identifying that there's something wrong with you. So many times some symptoms of depression, for example, can be explained by many other things. You might feel a bit tired. You think it's a problem with your iron, for example, or or something else, or you're not sleeping, and you might just think, it's the kids or that sort of thing. But if you put all of the symptoms together, and of course we can't do as yet anyway, there isn't a blood test to find out whether you are depressed or anxious, but there are clear signs, and if you put them in if you put the whole cluster of symptoms together, then you can see what's the problem. So I think identification, especially like you said with males as well, where they don't seek help, it's very important to identify. And I think again, I always tell my patients, know yourself. So I might spend a bit of time right as I start trying to find out, and they're a bit surprised because they came to tell me what's wrong, and I asked them, so what was right before? Because you need to have a comparison to how you were, what's
Your
the baseline.
Yeah,
exactly.
yeah.
Because I might not know. Someone may just be a bad person and that's just who they are.
Yeah,
But
that's the norm.
Yeah, that's their norm. Yeah. So they need to know what's their norm really in terms of all of it. What do they like to do? What's their enjoyable, their leisure activities, interaction with everybody, work, relationships, spouse, children, that sort of thing as well. But just to go back to the incidents, like we said, the other sort of condition where sort of males are predominate slightly more is of course with ADHD, attention deficit hyperactivity disorder.
Right.
But there is a subgroup ADD where the hyperactivity is present, where females are more than males.
So they're predominantly inattentive, the daydreamers.
That's the thing. That's the thing. But not the high. But there might be internal hyperactivity, which is very hard to work out. Is it just a lack of concentration, or is it actually lots of thoughts going through their head as well?
That's like more like anxiety as such.
Along those lines, yes. Yeah. But in terms of the treatment, you get parents who say, look, my child's got ADD, doesn't have ADHD, and it's in terms of the treatment is exactly the same, but it's nice to know what's the difference. You spoke about suicide, which is obviously a huge topic on its own. Yeah. But you're right. Yeah. So females would attempt suicide much more, but men would unfortunately complete suicide much more. And
they goal directed. They go for it.
Yes. But again, all of these statistics are changing, especially maybe in the last 10, 15 years. Yeah. Like with substance abuse, again, females want to be equal in everything, so they are trying very hard.
You're saying that as respectfully as you can, I promise you.
No, it's true. But similarly with males as well, and whether it's that we're recognizing it more, whether there's because of changes in all of it in social media is such a huge thing as well. So people identified that there is a problem. I think there is a bit less of a stigma with psychiatry and with psychology, with mental health, but there's still a huge way to go as well.
Yeah, and I think sorry to just interrupt you there. Here's this part that I always put up posts, and something came up. Somebody commented on, people don't believe this. Islamically, you just have to have faith, and then all this doesn't trouble you. And I think I actually got a bit worked up with that, because you feel bad enough if you're depressed, and then you're supposed to feel guilty because now you're a bad Muslim. I don't know if you get any of that.
I get a lot of that.
I mean, faith helps. I'm not saying it doesn't, but to say you don't have faith because you're feeling this way, I think that's a bit extreme, don't you think?
It is. I think, you have to distinguish first of all, and really what's the problem with depression and clinical anxiety is that you don't have a reference point. So I tell people, if you never broke your leg, you have an idea what that pain might be like. So it's like you fell, times 100 maybe. But with anxiety and depression, as opposed to sadness, it's not the same thing. So sadness is normal. We must not treat sadness because it tells us that there's a problem. It's like it's a symptom. It's like pain, saying something is wrong. Because do something about it.
It's a warning sign.
Exactly.
Listen to it. Yeah.
But with depression, it's such a problem. I myself describe it, and this is sort of going to sound a bit shocking. I see it as a kind of HIV of the brain from a network point of view, from a neurochemical point of view, in terms of that the very factors you need to be able to cope here and now are compromised. So you have a problem, whatever it might be something short term, long term, it might be a bereavement, lost your job, whatever it might be, and then you become depressed, which is a clinical depression, where you have all of the symptoms, and they can be many, many symptoms. Sleep, appetite, energy, concentration, enjoyment, irritability might be a symptoms, somatic symptoms. But these are the very things you need to be able to cope day to day, cope with your family,
decision making, self-esteem,
working, all of that. So if that is compromised, then your functioning is compromised, which means that you get more depressed, and you got a vicious cycle that you have to deal with. So it's something which is really, really tough. So from the Islamic point of view, I think this is a protective factor, but it's not just normal sadness or a weakness of the brain. And I've seen this with so many people that are very high functioning, are very positive. It's not the same thing. So you never use your symptoms or the anxiety as an excuse or a justification for your behavior. So, but you acknowledge the existence of it, and you try to improve and work as much as you can.
And I think already some people feel that I'm being punished. So when people say things like, Islamically you're a good Muslim, it actually adds to that feeling.
It does.
Yeah.
And people, I believe anyway, most people are good and they try to help, but they most often say the wrong thing. And I say,
with
when
the best of intentions.
Yes, right.
Yeah.
When you advise someone, you advise them based on their needs, on what's happening with them, not you. But very often that's what you do, is that you advise based on what you think is best for the person.
Yeah. But I think even, and you touched on a very important point there, the difference between sadness and depression, because now there's one way of looking at it. No one wants to be clinically depressed, but the other way, for every little thing, she's depressed. And it's not a depression. It's basically just a little bit sad.
That's right.
Oh, I couldn't go out today, I'm depressed. But depression is so pervasive, like you said. It's mood, it's you can't feel joy anymore, it's appetite, sleep, the way you look at yourself, the way you see yourself, thoughts of death. So I think it's important people realize the difference between also the time period. It's 2 weeks or longer. That's
right.
a long period. Yeah, and I have to bring this back.
Sure.
Why psychiatry?
Well, I think I think hopefully we all start off trying to help people and trying to improve things. And I found I did work in a few other fields for a few months here and there, and surgery and obstetrics and gynecology and in medicine. And I found all of those you do help, but I found that we weren't getting that I myself anyway wasn't getting to treat the whole person. But I think probably the turning point was when, and I don't want to go on talking about myself, but when I went to the UK I was supposed to go for just 6 weeks, ended up spending 9 years there.
Wow.
But at that time anyway, I think it changed subsequently. But they had a very, very good mental health system. It was basically what you had studied, which was the theory, which you didn't see existing anyway at that time in South Africa.
Yeah.
But where you worked as a team, and you had a team with social workers, occupational therapists, psychologists, all in one team, and they could treat the whole person. And we saw lots of improvement in lots of people. So I think it was a lot.
So you saw a system
lot
that
of jobs.
works.
Yes. So I think that was really what drew me to it, and I've enjoyed it since then.
Oh, that's great. So I think you saw the ideal where, with the proper treatment, with everyone working together, how much of difference it can make.
Absolutely,
Yeah.
because like you said, it's a holistic approach, and you can't treat one and not the other.
Yeah.
So even now working in private at the moment, it's a bit difficult because you don't have all of the other resources because of medical aid. I mean, there's lots of people that
And
can
people
help.
cringe when you try to refer them anywhere else. They're like,
Absolutely,
oh God,
yeah,
another
absolutely,
one.
yeah. But I think that was the main reason, really.
Right. And I don't know if you get this. I know it's like, I always laugh and say they're the last people they want to see, like dentists. They're the last people you want to see. How's the stigma around psychiatry? Are people open to coming? When is it time to come to a psychiatrist?
Well, most people would come would delay coming, sometimes even by years as well. I find what helps is word of mouth. So many referrals that I get are word of mouth where someone else has mentioned something, and I think if the person trusts their friend or family or colleague, then they're more likely to come. But under what conditions? So I think first of all, like we said, you need to identify that there's been a change in you, and almost everyone talks about how they realize that there has been a change in them, but it's a retrospective thing that they only realize after a few months. Actually, yeah, there has been a change in so many parts of me. Sleep, and sleep is one of the first things to go, but everything else as well. Irritability is a huge symptom, and they don't recognize that, and then they just sort of try to push through, and people around them might not even might not realize till a bit later. So I think first of all, identify, know yourself, know what's your baseline, know why you're doing things. Is it out of anger, or you really feel very strongly about something, and now you find that you're getting irritable with everybody. So if there's a change in you, that's the first thing. So once you've identified that there is a change, and you're not sure what it is, whether it's depression or anxiety, then at that point you don't have to immediately see a psychiatrist. You might even want to speak to anybody, speak to a friend, speak to the Maulana if you feel comfortable. See your GP, see a psychologist. But when the symptoms have been going on for too long, or you're getting suicidal thoughts, which are on a spectrum. Most people who are depressed are going to get suicidal thoughts, and most of them are not severe, but they're quite frightening to the person, because this is completely unlike them, and it's not in keeping with religion. But it is a suicidal thought, obviously, but the intent behind that is just that I want things to improve. I'm not happy with the way things.
I want these problems to end.
Exactly.
Yeah.
So it's more along those lines. And then again, if there's any so if there's no improvement, you've been to the GP, for example, you've been on some treatment, and again the treatment needs to be holistic in so many ways. You need to. I tell my patients there's 4 things that need to be sorted out in your life, or 4 things that can happen. All 4 things need to be in place at the same time. 1 is medication. 2 is the way you think, or psychology or cognitive
Cognitions,
behavioral
yeah,
therapy,
yeah.
whatever it is. The way you think is so important, the way you analyze things. The third thing is, like we said before, is that unfortunately with depression, life is not on hold while you're depressed. You break your leg and everyone says, just rest for 6 weeks. We'll go and get your tea and stuff. But when you're depressed, you have to do everything, and life goes on. You can't take a bit of time off from work if it's really severe. So, but what I say is you have to get back into life as best as you can. So even if you're doing 1/10 of what you used to do before, whether it's taking a walk, going to the gym, going to the beach, leisure activities, but also with that goes your diet, exercise. I think everything plays a role. And the last thing, which I think probably one of the most important things of the four, is you've got to solve your problems. And as best as you can. Sometimes you can't solve it because hopefully you're not the problem. But if you are, it's good as well because you can.
You have to have insight to work with that. Yeah.
Exactly. So I think for those reasons, at that point you need to then see a psychiatrist as well. And also in terms of the medication, it's quite no one really wants to take medication anyway. Then they don't want to take antidepressants because of the stigma. Then they want to take it every day, and then there's lots of people would come and
the horror stories. Are you talking about that?
Yes. And they would misinterpret symptoms from the side effects. They would also look, we do use bad medication at times, and I won't say we have to, but sleeping tablets and benzodiazepines that have a role short term but not long term. So people might have stories about someone else who got addicted to those. Whereas with
antidepressants,
antidepressants, you don't get addicted to it. In fact, you have to use it every day for them to work. So there's that understanding of what's important, what's not, and also to understand. Look, I might get a few side effects. I'm not expecting them, but I'm aware of them. So when you get it and you know that it's going to last. So in terms of psychoeducation, knowing what's happening, understanding when what the treatment. That I think is something that is difficult for a GP to do. They don't have that amount of experience as I wouldn't have with anything outside of my field. But very often a GP is or might be the first line as well.
Right. So, in terms of talking about that, because I've heard the horror stories where people go, anything but not an antidepressant. But it's nice for them to know, okay, this is expected. How long, every individual is different, but how long do normally the side effects last, like the general sort of?
Well, first of all, to say, the first thing is that the antidepressants are not a homogeneous group. Right. It's like saying I tried this antibiotic, it didn't work, so I'm never going to take antibiotics.
So that strain of it, or that type of it, okay.
And some of them work in completely opposite ways in terms of the receptors or different receptors that they would work on. So the first thing is that if you've had side effects with one, and again you're going to be clear that it's an antidepressant, not like I said, maybe an anxiolytic, short-acting anxiolytic or a benzodiazepine that can make you sleepy. So first of all, you've been on an antidepressant before, you've had side effects. It doesn't mean you're going to have side effects to others. But most of them actually don't have side effects. Everyone is worried, and I think rightly so, about weight gain. Right. As an example, and most of the antidepressants don't cause weight gain. In fact, it's only
that's a surprise. Yes. Lots of, especially females, come, I don't want to pick up weight.
Because
you don't
that,
know the challenges. Yeah.
So there's a few things. The first thing is that one of and we talk about. So if you look at the first generation, so to speak, antidepressants, we don't use them anymore because of the side effects. They work really well, but they would cause a lot of side effects. The second,
amitriptyline, is
that's one of the older ones, yeah. Although that's a bit of an exception because at very, very low doses, it's actually very helpful as a non-addictive sleeping tablet.
Okay.
But that we can talk about. But then again, you look at the second generation, so to speak, which are your SSRIs, your serotonin reuptake inhibitors, which are well known for a long time.
Ones, yeah.
And none of those of the second generation cause weight gain, for example, except maybe one of them where it's a desirable side effect. So with the elderly, someone who's not eating at all, it's a good side effect in that way. Having said that, you can get weight gain with any medication, but there might be other factors. So I say, look, it's fine. Let's just keep an eye on you. We know that you're not supposed to get weight gain. Make sure everything else is equal in your life. Sometimes appetite is poor when you're depressed. You lose weight, right. and then you feel a bit better. You start to eat, but you're eating the wrong stuff, so you gain weight. So it might be.
And you always have choice. You're hungry, you can reach for a carrot instead of a chocolate. A pill's not going to change that. Yeah.
But to answer you, sorry, the side effects would, if they are present, would probably last about not more than a week or so. And this is the thing. The side effects are more likely when you start or stop the medication in those few days after that. So if you're not if you're not taking your medication every day, then you miss 2-3 days and then you take it. Effectively, you are starting and you're stopping it every few days, and you're more likely to get side effects in those situations.
Right.
So again, just to advise people, and what I also encourage, especially in the first few weeks when I see a patient, is to feedback to me, because sometimes it takes maybe just a few weeks just to fine tune things, and then I may not see them again for a couple of months because they're doing well.
Right. And then, look, I know it's a very weird topic to bring up, but what about sexual dysfunction? Because many people, especially males, are afraid to touch antidepressants because the horror stories aren't there as well.
Absolutely. So once again, there's been lots of studies, and again, when you look at the studies, you have to be very careful. There is bias in terms of research. You know about this in terms of pharmaceutical companies. They have quite a big reach. Hope I don't get banned for saying that, but it's true. But so in terms of sexual side effects, they do exist. They are present. Again, with the there's about 4 groups, not even 4 antidepressants. There's 4 groups of antidepressants where they don't have any sexual dysfunction at all. Where there is, it's mostly in terms of a delayed ejaculation or delayed orgasm. It normally doesn't affect your libido, because libido is more tied in with depression, a lack of enjoyment, motivation, drive, etc., which should improve. And in terms of erectile difficulties, there's no clear association. So those are more likely a vascular cause, diabetes, hypertension, that sort of thing. And again, from the other groups, which are probably about 4 or 5 groups that you can get sexual dysfunction, it occurs in about 1/3 of patients. So it is something, and it is reversible. It's significant, obviously, but it is reversible, and it's also dose dependent as well. So if you drop the dose with some people, if they're doing well, then they.
So there's lots of choices. It's not just, as you say, a one size fits all. And I think every individual differs in how the medication would affect them.
Absolutely.
And I think this is, one of the perks of being here, where we talk about things that are not usually spoken about. So people now are not that afraid. And I don't know if, being a psychiatrist, you've studied for so many years, you'd know more of the options. That's the advantage of coming to the qualified personnel.
True. Slightly more than them these days, because they have a lot of information with Google.
So
they are almost on par with me.
Yeah, sure. Should have just got, how many years you have said, just go to Google. But the scary thing is, Google has the horror stories. Yes. Who's going to put a story about, horror stories sell? Who's going to say, hey, I'm doing well?
Exactly.
You get one of that and 100 of the horror stories.
You're right about that. Yeah. I mean, I give the example, you go out and you buy an appliance or so, and it works well. You're not going to go and post a positive review.
Yeah.
But if anything goes wrong and you don't get service from the company or feedback, you're going to put, okay, it's a bad example with telecom, but maybe, you look at some of... yeah. But that is it. So you've got to think for yourself. So what I do is, I mean, you have to be realistic. People are on social media, they're on the internet, they've got the internet in their hands. So I direct them to appropriate sites which are unbiased sites like for example in the UK, which are patient based, but they have the
more like support groups.
True. Yeah. But they have experts in them as well. Like one is one website which is quite good is patient.co.uk. It's just a very straightforward site, and you just put in whatever it is, and it gives you exactly the way it is. And like I said, it's not run by the medical fraternity. They are experts or specialists who guide the content, but it's very, very good in that regard.
So patient.co.uk. So what kind of information would
anything you want? So it tells you about conditions. It tells you about any medication. It's very, very extensive.
Comprehensive.
Very, very extensive. And even the Royal College of Psychiatrists in the UK does have lots of information as well, which is quite it's for the layman as well. So that's they've got a website as well that you can look at as well.
Oh, that's great. It's always nice to equip people with resources so they can get enough information and they can equip themselves. We've touched on some of the female stats, but I think we went over it very quickly.
Sure.
What do you think females, I think you said depression and anxiety, but do females actually suffer more from it, you think, in terms of depression, or do you think it's presented differently, or what are your thoughts around that?
So my own thoughts would be that even if you exclude the factors that we're going to talk about now as to why females might be at a higher risk. So you ask yourself, are females at a at a higher risk, or is it an apparent higher risk where it seems to be higher risk? But even if you exclude and you deal with all of those factors, I think females would still be more at risk of mental health disorders than males, but not by much.
Okay.
So the factors, and once again, it's hard. It's difficult with research because of availability. We don't know exactly how many people are depressed. For example, we have stats, but
Sometimes not a
but not
true
comprehensive.
reflection.
Yeah. So first of all, is the hormonal issues that you discuss,
Yeah.
and that's something which I think hasn't been proven either way. But there are certain. So I think it's not that if you're depressed and you're a female, then we always need to consider hormonal issues. I think it's at certain times.
That
So
would,
at
yeah.
times. At times of puberty, for example, in times of menstruation, premenstrual,
And the DSM even recognized this as
they-
premenstrual, I think dysmorphic or
dysphoric
something.
disorder.
Dysphoric,
That is, yeah. So that's quite an interesting one, because it's not your PMS, but it's similar symptoms, but it's an exaggeration of that, where it impacts on your functioning. And so it starts a few days before you get your period, or almost every month. They say like 10 out of 12 periods, and then as soon as you get your period, starts to improve, and then for like the 2 weeks in between, you're absolutely fine. So it's rare to see that, but you very often see a premenstrual exacerbation of symptoms.
Right.
So the hormonal and many females do come to me and say, look, let's do the hormonal test, and you're going to do it to get a good idea. You have to do it at a certain time in the period, and the one constant thing about the female period is that it's inconsistent. So it's very hard. But
I think practically you ask any husband and they'll say, no, there's truth to
they know
that.
it. So that's the thing. But so you look at puberty. But another clue that there is a hormonal association is in terms of the postpartum period, where you can get a few conditions, and there's a significant increase in all of it in baby blues, they call it, where you might be sad or depressed for a few days, and then in terms of postpartum depression, postpartum psychosis. So and these have an association later on with illness, or may have an association. You are at risk of, for example, becoming bipolar later on in life. But again, there's other factors to consider. But then, so there is a clear association with hormones at that stage as well. So this is one thing I think which, if we exclude the other factors that I'll mention now, this is something which is unique to females. But the other thing is that there's actually been quite a few studies to look at why females, or why is it actually, and then you look at things are maybe improving in terms of females, in terms of their status in society. We're talking more from a Western point of view. But I think there's still, unfortunately, a lot of social inequalities. There's female gender-based violence, which we know has been in the news, for a long time in the last few months, in terms of earning less than their male counterparts, in terms of their social status in many countries. Even unfortunately, some of the so-called Muslim countries, where Islam or religion is used to keep females to keep females subjugated. Then so if you look at it, it depends what you might be predisposed to. So with for example, with sexual violence, there's a much higher incidence of post-traumatic stress disorder in females because of this sexual abuse, or even violence at the hands of a partner as well. And then the other thing is, I suppose in South Africa as well, this is quite important in terms of the work overload. So especially in the lower socioeconomic situations, females are expected to do everything, raise the
Many
family
roles,
and
yeah.
work and support the husband as well. This is a generalization, I know that, but it still is occurring. I think things are improving. And then there's the issue of single mothers, of single parenthood, and then having to care for the mother or the mother-in-law, that sort of thing. So there's a lot of other factors that I think would cause anyone to be at a higher risk in terms of in terms
Women,
of being
to some degree,
depressed.
are predisposed or more vulnerable.
Absolutely. And this is independent of any biological cause, so to speak. But also what they found is that doctors are also part of the problem without realizing it. So there's a bias in terms of diagnosis, where doctors, professionals are more likely to make a diagnosis of mental health problems, depression, anxiety in females as opposed to males, even if they present with the same symptoms and the
That's
same
interesting.
circumstances.
Yeah.
Yes, and also they are more likely to prescribe medication for females than for males. Now, part of this might be that females might be more amenable to open to taking medication as opposed to males, but again, this will skew the statistics as well. How many people are using medication, females more than males. So obviously, they're more depressed, but it's not like that. And then again. The other thing is, like you said before, females are more likely to seek help. They exposed at various, at various parts. First of all, in their lives, in terms of friends, colleagues, etc. But also they would take their child to the doctor, for example, or they would need to seek help or see the gynae for some problem. So it's more that it's recognized, and generally, and this is a generalization, but females are more open in terms of discussing problems. But I think that is yeah. And then again, the other reason could be a bit of a biological or an organic cause, we say, like problems. So it's not depression itself, but a medical condition which would cause symptoms similar to depression, like problems with thyroid are much more common in females than in males. And then in terms of eating disorders, for example, although that is changing, but there's a body image disturbance with females as opposed to males. But like I said, that is unfortunately changing as well. And the last thing is that back to the hormonal thing is in terms of not all of it, but in terms of the oral contraceptive pill or hormonal therapy, that might some of them might exacerbate symptoms as well. But I think these would explain why females. So the bottom line really is that females are more at risk, I think, but it's not as high as the results indicate.
Yeah. What about how they present? Because I'm just thinking about in my practice, many
Sure.
people will drag men in and say he's angry, anger management, but it's a depression, or substance use. But so are they presenting differently? Maybe that's why some of the confusion.
Absolutely, and I think you've really hit the nail on the head there in terms of. Males would generally present more with irritability, anger, violence, whereas with females it would be symptoms that you would expect, sleep, etc. But more somatization, more external symptoms, headaches, pain. There was a study done, I can't remember when, but I think about 80% of patients with chronic pain were depressed, and they would present to their GP. So the problem wasn't the pain; that was a symptom of the problem. But I think you're right in terms of the symptoms. It's more along the lines of aggression. It's more in terms of with males they would present if they had to be persuaded to, if there was an incentive to do so,
Or a threat.
a threat, exactly. The wife says, "Look, I've had enough," or that sort of thing. Whereas with females, they would recognize that they need help, but very often again it would be that they would actually try to that they would hide it from their spouses, from their husbands or their boyfriends at that time, because of the stigma. Stigma in many ways, that the person would blame them, or blame all of their behavior on the depression. You just act like this because you're crazy, or what they perceive to be side effects of the medication at that point as well. So unfortunately, as I said again, that is improving. And what I always try to do is with the person's consent is to try and see someone who's important to them, so I could educate them as well. And usually
The family
it is
support
the
and
husband.
understanding
Yeah.
is very important.
Absolutely, yeah.
We've come to the end of our time, but before we close up, is there anything that you would like to share with our listeners? Anything we left out? Any words, parting words of wisdom?
I think this is a huge topic, obviously. So just So I think there's just a few things, and as I said before, just you need to know yourself, understand yourself. You need this is a cliche. You need to love yourself, but to love yourself, you need to know yourself, the good and the bad in you, and that will give you an idea, not just in terms of when you are depressed or anxious or anything else, when you need to seek help, but also how to deal with it, how to solve the problem, and how to define what your worth is. So this is going a bit more in terms of psychology, but it really helps, and I think that it helps the treatment that we give. It helps the medication
Care
much
for
more.
yourself.
Absolutely.
Yeah, right. And I love those words because we forget, and I think especially with men, there's not so much of sympathy when they come up with depression because the way they present is so confusing. So I think those words really mean a lot where you say care for yourself, love yourself. It's not your norm. You're not the enemy. So when you think of it that way, maybe they'd be a bit more amenable for treatment. And so to end, for the thought of the day, I wanted to just bring in the Quran a little bit because it says that after every hardship there is ease. Allah subhanahu wa ta'ala speaks about being tested in the Quran, but also hope. The world is for tests, and with these tests we grow as people and grow closer to Him. He has also promised that there will be ease after every hardship, as I said. So look forward to that. Know that your situation you are won't be forever and that you will get through it and you will feel amazing again. So just strive and look for a solution, inshallah. And next week, we will have Dr. Asya Desai with us to discuss the change of life in females, what to expect, impact of the period. We spoke a lot about hormones. We're going to get a little bit more into that and how this affects our mood and health and options in terms of HRTs. So from me, your host, Nazia, ma salam. Remember, be kind, be mindful, and have a great week.